Okay, I see that we are at 9:30, so we can go ahead and get started with our session. A clinical session is soft skills and communication in the clinical setting. I will pass it off to Lisa. Lisa, I see that you're here.
Yes,
Go ahead
good
and hand it off to
morning.
you.
Let me take my remote control. And I had similar questions to everyone else. What's my MD-PCP ID for my pretest?
That's only if you are at an MD-PCP practice, so you're welcome to just put all zeros or leave that blank.
Got you. Thank you.
Absolutely, no problem.
So good morning, everyone. I have to say, Dr. Rebecca Etz is a really tough act to follow. Thanks, y'all, for putting me right after her. I will say that I think you're going to see a lot of overlap between kind of her main message and mine, hers from a more academic perspective, mine from a more personal perspective. But I found myself just nodding my head, yes, yes, throughout her entire presentation. So good morning, I'm Lisa Lindstrom. I am boarded as a family nurse practitioner and also psychiatric mental health nurse practitioner. I worked full-time for 2 years in addiction psychiatry, but my personal goal in going back to school for my psychiatric degree was always to enrich my practice by blending physical and mental health. I'm currently the nurse practitioner and COO at Urgent Wellness in Southeast Washington, D.C., where all of our patients have Medicaid as their insurance. Today, I will attempt to share some insights into bringing psychiatric treatment principles into your physical health practice. The objectives that I was told to cover today are plentiful. So please, each topic will be addressed briefly so that you can put questions in the chat and we can come back to the ones that maybe are more interesting to people at the end. So disclosure statement, I have no actual or potential conflict of interest in relation to this program presentation. My personal goal for this presentation is that everyone learns and implements at least one new tool or practice to improve their patient care. The official objectives are talking about effective patient-centered communication, teamwork, conflict resolution, as well as specific tools on root cause analysis, debriefs, and closed loop communication with patients, staff, and I wanted to add with other clinics and hospitals, which is something Dr. Etz had touched on. Please submit questions into the chat, and at the end, we can go over the questions and see if there are topics that interested you all, and we can go more in depth into those if you like. So story. This is a true story unfolding over the past 12 months. We'll come back to this story throughout the presentation to illustrate a few points. Mr. D, 47 years old with obvious musculoskeletal and nerve pain, several social determinants of health factors like being incarcerated for a few years and getting out a few years ago. He has mental health concerns, low health literacy, distrust of the medical system, and he's asking for pain meds. So, poll question. After sitting, you walk him back, and after sitting in an active listening position, making appropriate eye contact, you ask how you can help him. He takes a few minutes to explain all the above information that I just had on the previous screen. What do you do next? So take a look at, this is going to be an interactive poll question. We'll have a few of these. Take a look at these. And once, I think we decided once we have like 50% of the answers back, we'll go ahead and talk about it. No one's keeping track of your answers, so you can be honest and not just with what you would do and not just what you think you should. Okay, it seems we have overwhelming majority of people who, let's see, go to my next. I think
We're at 50, so I can go ahead and end the poll if you'd like, Lisa.
Sure. Should I end the poll? I think I can do that.
Yes.
Actually, all of these answers are appropriate, I believe. They are all reasonable responses. They are all real world, realistic responses. They're all things that we would like. We do at some point want to know why he was in prison. We do at some point want to hear from his wife about her perspective as a collateral. We obviously need to start our HPI. And in order to start laying the groundwork for trust in this relationship, it is kind of using some of the psychiatric principles of acknowledging that he's dealing with a lot of challenges, and that, you know, I am committed to working with him as a team to improve all aspects of his health. For me, that includes physical health, mental health, and financial health. That's a sidebar, though. One of the first things I learned in my psychiatric program is to notice how I was feeling in the room with the patient, because it mirrors what the patient is feeling. So if I am feeling anxious, it's because that patient is feeling anxious. If I am feeling distrustful and not maybe believing what he's saying to me, it's because he is distrustful of me. It's that was a huge lesson, easy to say, hard to do. But we can change the energy and the mood of the room and the entire visit just by taking a 3-second pause, like literally counting, you know, 1 Mississippi, 2 Mississippi, exhaling, and it can make a huge difference just to kind of exhale all of the tension in the room. The patient feels that. So story continued. Next, you do your thorough history and physical, of course. The end, you diagnose him with polyarthralgia, peripheral neuropathy, history of discharge with a firearm with undetermined intent, and a lot of Z codes, but including one related to problems with release from prison. This is all you have time for today. You order some gabapentin for him, some labs, tell him to make a follow-up appointment in a week. Instead, he calls back 3 days later, true story again, asking for, quote, something stronger than the gabapentin, which I declined. He misses his next appointment, his 1-week follow-up, and comes back 3 weeks later saying, quote, "You are all the same and don't care about people suffering." He has not gotten his labs done. You've seen a variation of this patient many times before and can predict how this will go. A cycle of missed appointments, increased anger on his part when you do see him, until you don't really know what to do with him anymore and you refer him to pain management. I have seen this many, many times at different practices over my 20 plus years in the field. So our reason to change is the standard method of care is not working. We got to change if we want something different to happen. We're going to go over tools, systems, communication methods that can help improve this patient outcome. This is something called a root cause analysis, and this is a fishbone diagram. This is something that, you know, while I don't think most of us are probably drawing fishbone diagrams for each patient, these are things that we do consider. This is just a visual format for it, and a business format for it. So patient factors. We like to blame patients and call them, quote, non-compliant, right? Lazy, drug seeking, they don't care about their health. All of those are assumptions and judgments. We know that. This is where social determinants of health and other factors come in. Why was Mr. D defensive? Why was he not willing to put his faith in you or listen to you? Why did he miss his appointment? Why did he think he needed more pain medication? Why didn't he get his labs done? Answers are, in his particular case, time, money, transportation, other family obligations, and just a basic of he had no way to really organize his thoughts, appointments, and instructions. Which brings me over to supplies. In this particular patient example, and actually for all my patients, I offer them, if you can't tell someone to monitor their blood pressure and come back and tell you what it is unless you really give them a notebook and a pen, right? Giving somebody a little notebook and a pen, they don't really have an excuse. It's kind of fun. I have such amazing compliance when I give people just simple tools, right? Another supply, well, I consider a supply, is the electronic health record and CRISP, which is our health information exchange. which allows us to have easy access to the patient's records. Team. Team is we need to have a strong clinic team that communicates relevant information and concerns about patients and processes. We need to form a team with the patient. We need to have a team within the clinic staff, and we need to form a team with the outside specialists who they are also seeing. Individual staff, this is really important. Is the front desk staff being, kind and welcoming to him, even if he is being a little bit aggressive? How about the provider? How is the provider as an individual interacting with this person? Processes. Mr. D was not able to really provide me his diagnoses, the medications he was on, the specialists he's seen, any imaging he's done. I think it was because he was just overwhelmed and in a lot of pain that he didn't feel like trying to remember, which is understandable. So we need to, I very quickly after joining this practice realized that I needed to kind of crisp someone in advance. I use that as a verb. I needed to crisp people in advance, look at their past records, review them, what kind of imaging and treatments they've had at other locations. And in terms of processes, we need to let the patient know that this is going to be a process. This is not you show up, tell me your problem, I fix your problem, and you move on with life. This is a process that we are going to work on as a team, improving the patient's health and the patient outcome. Institution. So institution means from the individual clinic level, if you work at MedStar, the entire MedStar chain, the healthcare system, the pharmacy chains, insurance plans, in his case, the criminal justice system. These are things that are a lot more difficult to change, but we need to be aware of them when we are thinking about how those impact our patient outcome. For Mr. D, the current healthcare and justice systems have been prejudiced and dismissive of his basic needs of respect and fairness. We have an ethical obligation to provide healthcare for all without judgment and with acceptance, genuineness, and empathy. This is coming back to something that Dr. Etz mentioned in her talk as well, right? Just being there and bearing witness is such an essential part of primary care. Poll question 2. No right answers here. This is just me being curious. Which of those kind of fishbone aspects do you plan to address first with your next, quote, non-compliant patient? Okay. Next is closed loop communication. This is something that we do in the emergency room, typically, right, when we're in like a high intensity situation. In primary care, it looks more like me asking my office manager, Kim, please call Mr. D for follow-up on his podiatry appointment. Kim says back to me, okay, I'll call Mr. D to make a follow-up about his foot doctor. And I say, confirmed, thank you. So making sure, that we understand each other. Better yet, of course, instead of just verbally asking, is to use the messaging, patient cases, whatever the case may be in your particular electronic health record, to document this for Kim and to show in his chart that you are trying to close the loop with the patient after their specialist appointment. We want to close the loop with staff and with patients. We want to always confirm that other people are hearing and understanding what we are saying as individuals and as a healthcare team in general. Did Mr. D understand how to make his podiatry appointment? Did we give him a paper referral? Did the staff highlight the phone number and instruct him to call that office to make an appointment? After the specialist appointment, did he understand the diagnosis and instructions? Did he get the medication, imaging, testing that they recommended? If not, why not? This is our job in primary care, right? Is to pull together all of these threads from all of these different parts of the healthcare system. Very, very often my patients did not get the medication that was prescribed by the emergency room, by the specialist, because it's not covered by their insurance. because the ER does not check your patient's insurance formulary. They were rushed by the specialist office, given a stack of papers at discharge that they don't know what to do with. So they don't complete their homework and they appear non-compliant. Maybe we don't use the poll this time because I'm having challenges with that. Poll question 3. So just think about this to yourself. What keeps you from closing the communication loop with patients and staff? Time, because yes, it takes time. Technology, is there too much else to keep track of? Or is it lack of previous training? No one's ever kind of told you to do this before. Okay, yeah, mainly time, too much else to keep track of. Perfect. Thank you, Raghavi. So next, debriefs. Again, this is something more typically used in an emergency room right after a patient incident. Sadly, it's usually because some things did not go well, but this can be really effective in building team culture when you actually debrief on something that did go well, right? Let's not just save these for bad news. So these are important after an acute patient incident. They may be emergent enough that they require immediate attention, right? Like after an ambulance is called to the clinic, after a patient becomes aggressive in some way. They can usually, though, wait until the end of the day for lunch, for a weekly meeting. This is where all members, everyone who works at the clinic, can share their insight on something patient-related that could have gone better. For example, in our earlier story, if Mr. D is calling the office 3 times in a day and telling the front desk that he needs tramadol, that assistant needs to kind of let me know that, and we both together as a team need to decide how we're going to handle it. And of course, it's best if we can prevent a patient incident or outburst in advance. So with honoring people's privacy, if we know that one of our patients is going to get bad news, got bad news, something else is going on in their family, we don't have to disclose what's going on with that patient to still be able to say, to ask the staff and say, look, I need you to know Mr. D's going through it today. Just please give him a little bit of extra care and patience, just so that the staff does not react to his high energy, low level hostility. Again, this is just pertaining to my one patient. Conflict resolution. So this can be with patients, with staff, and so regarding staff conflicts, in the past, I've had a provider with a combative attitude with a few patients and also was being disrespectful of a staff member. We had an open staff meeting over lunch, sitting in a circle, like group therapy, because that's what you get when you have a psychiatric NP in your practice. I facilitated it, and we had very strict rules about speaking calmly and factually about our feelings when interacting with others in the office. It turns out that the provider did not want to be told what to do by this other staff member because this other staff member was younger. We talked about how everyone in the clinic has a role and a perspective that is vital to the effective operation of the clinic. The 2 staff members actually agreed to share their feelings about what was going on with the group. Another staff member bravely shared her feelings about what was going on with the group and how it made her feel as being an observer of the conflict. And this had really positive results. We did have to let that provider go about a month later. But what we were left with was that the other staff members truly felt valued as individuals and saw proof that their feelings and contributions are valued by the organization. When we all put the patient's health first, we respect each other's roles, and as individuals, we have the best possible outcomes for the patient and the clinic. Regarding patient conflicts, When we're dealing with patients, they are not coming from a healthy place. They are sick, injured, dealing with significant stressors. They have mental health issues, substance abuse issues. No one at the clinic can take a comment or an attitude of a patient personally. It has nothing to do with us, right? They have their own lives, stuff's going on in their own life. We are there to serve them. And if we just need to let the patient vent for a minute, before telling them that, like, look, I want to help you. Like, I'm on your team. Please let us help. It can make a big difference in the moment and in building a trusting, caring relationship between the patient and the clinic staff as a whole, moving on. I know I'm talking a lot. I warned you all about that in advance. Communication systems, educating the staff. This is can be as easy as just having, every 2 weeks, once a month, having a paid staff lunch, sit down, using real patient interactions without any judgment. This is the hard part. Some with good outcomes, others with poor outcomes. Let's talk about things that have been effective and ineffective in improving relationships between the patients and the clinic. Before you do this, you need to have some positive examples of individual members of the team, or the entire front desk team or something. We need to have examples of them stepping up, being creative, calm, solving some problems, and keeping like an open line of communication with the staff, letting them feel empowered to actually give you feedback, being open and not defensive. If you do open yourself up to getting feedback, is essential. And this just makes such a big difference. Technology and data sharing. All I can say is let's use technology for good, which brings me to my next poll question. Are you using electronic record sharing or health information exchange in your typical care of a patient? So typical care. This is, in our region, it's using CRISP, or it's at least, if you're working, say, within MedStar, you're at least looking at their records within the MedStar system. Oh, I'm so happy. We're all CRISPers here, huh? Excellent. Thank you so much. So for those of you who are or are not using CRISP, I have, this is a screen grab of what my record looks like on CRISP. You'll see at the top, my name. This is the, the health records page. I have the radiology tab pulled up because this I thought was a good illustration of looking at over the past 5 years. You can see imaging that I've had done at GW, at Washington Hospital Center, at private Washington Radiology Associates, at Sibley, which is part of the Hopkins system. You can also look at their past labs and to see, what was their A1C previously, because right now it's at 8.5. We don't know if that's good for them or bad for them. We need some context. Over in the structured documents part at the top, we can actually see results from, in our area, it is like Unity, like the federally qualified health centers. Unity shares their notes in the CCDC format. So make sure that your clinic, your organization is signed up for CRISP, and make sure that each individual person has their own CRISP account. So a lot of times, so many people that I meet, their organizations just have not told them about this. And anyway, we use it mainly just for checking to see like how many opioid prescriptions have they filled at what pharmacies, by what doctors, trying to see if it looks like they are drug seeking or have an addiction problem. Client-centric communication. This is a concept in business in general, not just in healthcare. It means that by putting the client satisfaction at the center of its mission, the business benefits from customer loyalty. In healthcare, it means not only the clinic, but the patient benefits as well. Most of us know this healthcare operations sphere, but we really need to know the culture and values sphere as well, as the strategy and vision of how we are going to constantly improve healthcare. A system example in practice of using client-centric communication can look like letting the patient decide how they would like to be contacted. Phone calls, texts, phone apps, emails. In the exam room, staying patient-centric means seeing the patient in front of you as your purpose, recognizing that you are in the literal seat of power in that room, and also that the patient is just as important in this process. In psychotherapy, we spell out the boundaries and the roles of each person in the room. That is something that I believe we can borrow in primary care, and I do every day. Personally, I tell my patients that we are a team. I say those words literally out loud. It's their job, and I tell them this, it's your job to know what's normal and not normal for your body. It is my job to sort out what's going on and offer you options. There is a communication and care model called shared decision making. For Mr. D, his uncle had died of prostate cancer, and prostate cancer, I think this was the first time I learned about shared decision making was when the recommendations came out around 2013, 14 about not just offering the PSA test as standard at a given age based on someone's race, but using shared decision making to decide when and if to offer the PSA blood test. So this is just like it says on the graphic, it is seeking your patient's participation. And again, saying this out loud. Mr. D, I want us to make this decision together. Then, sharing the information, the pros and cons of getting the PSA test, for example, assessing the patient's values and preferences. When you straight up ask someone, what are your values? It's a little bit ambiguous. It's important to, if you've noticed this patient talking about their family a lot, I can see that your family's important to you, or you expressed earlier that, you're not a fan of medications and interventions. You prefer doing things a more natural way. So that you can reach a decision with your patient, and then not in the moment, but on follow-up, you will evaluate your patient's decision. So many of my patients have felt like decisions that they make about their healthcare are irreversible. And that's something that I stress to them. This is not, we can try option A. If you want, next time in 3 months, we can try option B. And if you don't like that, we can go back to option A. I'm fine with that. Poll question 5. If you use the shared decision-making model, how satisfied are you with the outcomes? Some people haven't tried the model. People who have are generally satisfied. Empathy. I want to go back to something that Dr. Rebecca Etz spoke of in the keynote. She was talking about intention and how it is your intention that really matters. And we learn this in therapy. It is not, people are so worried, providers tend to be really worried about the exact words that we use when communicating with someone. The exact words are not what's important. You can't be so afraid of saying the wrong thing that it keeps you from taking action or communicating. Even if the words are not perfect, don't be scared. It is the intention. Like she said, your patient knows when your heart is in the right place. Your patient knows if you are judging them or not, if you are truly caring about them that day, if you're really thinking about your lunch order in the back of your head, your patients know. And as I mentioned in the fishbone diagram previously, we have an ethical obligation to provide care for our patients with empathy and lack of judgment. We must always try to care for our patients as if they're our friends and family. We don't know about their past, present, or future. I know we all know this, right? No matter how busy we are, I do recommend taking that 3-second pause that I mentioned earlier, and exhale, and considering like how we think the patient is feeling in a particular moment during our visit. Another, I think that all of us came into this field for the right reasons, right? I don't think we came into this for the money. But burnout is a major, major factor in how we lose empathy for our patients and we lose our passion for the job. That whole topic of burnout is for someone else to address. But I think being aware of when we are burned out, doing the self-care, changing priorities, doing whatever we have to do so that we can get back to being able to be in a place where we can be empathetic for our patients. Active listening. So motivational interviewing teaches this in spades. You likely learned it in school, and I highly, highly recommend that you take some time. There are free training courses online. University of Indiana has a outdated but very effective free module on this. There are so many free videos that are all over YouTube. I have a link at the end. Motivational interviewing is where the provider does not make any recommendations. We only ask questions. Questions like, tell me more. Tell me more is such a fantastic phrase to keep in your back pocket. Tell me more about your experience with physical therapy. Tell me more about your support system. When we use motivational interviewing properly, the patient comes up with their own treatment plan. You don't. You ask questions that lead them to their own. You never give any advice. They end up talking themselves into, reducing their cigarettes, agreeing to try taking their medications consistently for a month, to start exercising, to decrease or stop sugary drinks, to show up for their appointments. It addresses patient behaviors, and behaviors are what drives compliance to a treatment plan and thus improved outcomes. I think you can see a common thread here with the compassion, acceptance, empathy, partnership that's kind of been going through the whole talk. The payoff, if we start using some of these tools, is improved patient outcomes, improved clinic, improved community impact. And I have to give you the update on Mr. D. So I started seeing him in May or June of last year. He is fully compliant with all of his appointments at my clinic and at his specialists. He can not only walk without a limp, but he is riding a bicycle. Because he is not in so much pain, and he's able to have social interactions along with an SSRI. We have brought his severe depression into remission. I think I forgot to mention that he had attempted suicide about 6 months before I met him. Turns out he has a true pernicious anemia, so he is now administering his B12 injections at home, which made a massive, massive difference in his pain level. He's had corrective surgery on his right foot that had been impacted by a gunshot wound. He's received steroid injections to his knees. He's able to care for his mother, which was a driving force in him improving his health. He wanted to be able to care for his aging mother. And he is on no pain medications. The man who called in 3 times a day and was begging for tramadol is on no pain medications. When he comes to the clinic for follow-ups, he is like our personal clinic cheerleader. He smiles. He will evangelize to people in the waiting room and say, you got to listen to these people. Okay. They actually really care. So just, like call Miss Kim if you need anything, talk to Lisa. You got to be honest with her, because if you do, she's really going to help you. He's so hilarious, and it's because he is healthier than he could have ever imagined, because we formed a solid team with everyone in the clinic, with me, with him, and he bought into our team plan. Summary questions. These are optional because we only have like 3 minutes left. I know that you all want to do summary questions, MD-PCP, and I also do want to see if there's any questions that people wanted to ask. So up to you how you want to handle it.
Yeah, if folks have questions, they can raise their hand or drop it directly into the chat. The poll is live, so you're welcome to vote while you're also typing in questions.
And so I see that Ms. Taylor asked earlier, or she commented earlier, that some people don't feel safe sharing why they were in prison, because they don't want to be judged and risk not having appropriate and respectful care. I agree. I have never asked any of my patients, and I have many, why they were in prison. If it's relevant, it comes up in the course of time. But I personally, I don't ask why. I have yet to meet someone who does not have PTSD from being imprisoned, and the things that they witnessed, the things that they experienced. It is heartbreaking and so much work to for them to kind of adapt to society. And I highly recommend getting them into a reentry program for returning citizens. They are easy to Google and look up in your area. Yay, people are going to look at motivational interviewing. Number 2, the root cause analysis, looking at the contributing factors. I was not trying to be flippant when I made up those questions or the responses. So maybe the staff is lazy. Maybe the clinic ownership is out for the money. Maybe the patient is being rude. Those can all be true, right? But the root cause analysis is looking more for the reason, why is the patient rude? Why do we feel that the clinic ownership is out for money? Why is the staff lazy and not doing their work? So the root cause analysis factor would more specifically be the clinic doesn't have a standard method for reconciling medications. And yes, Mr. D's improvements are because of teamwork and using the tools. Like CRISP and motivational interviewing are really the 2 main things that I hope that everyone, personally, I hope that everyone gets out of this, especially in avoiding repeat imaging. Thank you to everyone for attending the session, being open-minded. I can share, my slides are free to share with anyone who would like them. You can email me, lisa@urgentwellness.com, with any questions, comments, concerns. I'd love to chat with anyone. Thank you so much, MD-PCP, for inviting me. I've never done anything like this before. You could probably tell, but I'm very passionate about my role and my call to service. So thank you for letting me share.
Thank you so much, Lisa. It was lovely having you here, and we'll share the slides after for folks who are interested in reaching out to you.
Perfect. Thank you so much.
Thank you.